So by far the most common reason why patients come into the hospital is for pain, and chest pain is probably up there in terms of the top 5 diagnoses that people come into the hospital for. And that's because the community is always really concerned that that episode of chest pain could potentially be a heart attack. And a lot of that has to do with the fact that we've had a lot of education in the community about warning signs for a heart attack, and so patients will often come in for chest pain. So that's a very common reason why people come in, as well as other pain diagnoses or pain complaints. A lot of patients have pain in different areas of their body that will also trigger a visit to the hospital. The other most common reason why patients are coming into the hospital, whether they know it or not, is because of infection. So whether it could be a strep throat or a pneumonia or a urinary tract infection, by far it's one of the top reasons why patients will come into the emergency department and seek care. What it entails is essentially establishing rapport, identifying what changed that day that induced a visit to the emergency department, whether that was because someone brought them in by EMS or because they came in because they were concerned about something. So once we establish the rapport and I have an idea of why they're there, then there's testing involved sometimes, not all the time. Sometimes all I have to do is reassure the patient that what they're explaining or describing is perfectly normal and is limited, and they'll be fine and they can go home. And the vast majority of times, however, we're doing testing. So that testing could be anything from a special examination, additional laboratory tests, diagnostic tests, imaging, and sometimes even beyond that, we have to call in a specialist or a consultant to help us to decide exactly what is going on with the patient. Once all of those studies and those consultations have come back, then we have an opportunity to really compile a plan for that patient. And we usually discuss it with the patient, and they tell us whether or not they are amenable and agreeable to what we have in mind. And the patient is either admitted to the hospital because the condition is serious and there's a risk that they could have a poor outcome or some sort of complication from not having it treated, versus being sent home. There's not a specialty that we don't interact with because essentially everybody comes to us and we have to figure out who we need to help us make decisions. So in trauma, it is not uncommon for us to have to immediately be working with our trauma physicians or orthopedic physicians, our ear, nose, throat. Sometimes anesthesia will come down and assist with really complex airways if they can't be managed in the emergency department. When we have patients that have a heart attack, the cardiology team comes down. When we have a patient with cardiac arrest, we have cardiology, intensive care, neurologists that are involved. There's probably not one specialty that I can think of that we don't interact with to some extent in the emergency setting. And again, I think we take pride in learning their language, but in communicating with all of these specialties, because it's the only way that our patients get the care that they deserve when they arrive. That every single one of us in emergency medicine really aims to enhance care so that our patients are satisfied at the end of their visit, or at least we exceed their expectations. And a lot of that also has to do with listening to the patients. A lot of our patients, as I said, are showing up on the worst day of their lives, or have a lot of anxiety about their medical conditions, or just curious about something that's been, that they've been suffering for some time, and they haven't gotten access to another physician. And to the extent that we not only address their issue, but also address their emotional state, I think that we can move forward. I think that one of the biggest frustrations that patients often have is feeling like they're not being listened to. And I think the challenge in emergency medicine is to always make sure that we're acknowledging patients, not only based on their concerns about their medical conditions, but also acknowledging that there's an emotional state that's driven them to being in the emergency department, and we shouldn't take that for granted.